Primary open-angle glaucoma. It is a bilateral progressive rise in intraocular pressure in the absence of angle closure, peripheral anterior synechia, resulting in optic nerve damage and visual field defects. Risk factors: age, middle age and elderly. 2% of population older than 50 years have primary open-angle glaucoma. Sex, equal in both sex. Race, 4 times more common in black races. Blindness from glaucoma is 4 to 8 times more common in black races. Family history, positive, more common in myopes. The condition is bilateral but asymmetrical. Heredity. Primary open-angle glaucoma is an autosomal recessive disorder. 6 primary open-angle glaucoma genes are at fault. Glaucoma 1A, 1q21, q23. Glaucoma 1B, 1q-CEN, q13. Glaucoma 1C, 3q21, q24. Glaucoma 1D, 8q23. Glaucoma 1E, 10P. Glaucoma 1F, 7q35, q36. Pathogenesis. Decreased aqueous outflow facility. Progressive sclerosis of trabecular meshwork results in narrowing of spaces of Fontana with subsequent decrease in aqueous humor outflow. Resistance of aqueous humor outflow lies in juxtacanalicular tissue between trabecular meshwork and endothelium of Schlemm's canal, with loss of giant vacuoles in inner wall of endothelium of Schlemm's canal. Anterior chamber angle is open gonioscopically, with insidious elevation of intraocular pressure. Hypersecretion of aqueous humor, which is very rare. Microscopically, there is loss of trabecular endothelial cells, with fusion of trabecular beams. Decreased porosity and obliteration of trabecular cul-de-sac abutting juxtacanalicular connective tissue. Thickened basement membrane by collagen, amorphous plaques, elastin-like materials deposition. Abnormalities of giant vacuoles in Schlemm's canal endothelium. Histology. Closure of Schlemm's canal. Deposition of glycosaminoglycans or other material in juxtacanalicular connective channels. Sclerosis in scleral spur blocking posterior uveoscleral outflow. These changes may reflect exacerbation of aging process. Prognosis depends on the following factors: patient's age, severity of the disease. Most patients with primary open-angle glaucoma will retain useful vision. Incidence of blindness from primary open-angle glaucoma: 27% in one eye at 20 years follow-up, 9% in both eyes at 20% years follow-up. Prevalence of bilateral blindness is 8% in blacks and 4% in whites. Secondary open-angle glaucoma. Classification: trabecular mechanisms. Clogging of trabecular meshwork by cells, red blood cells, white blood cells, and tumor cells. Pigment particles, pigmentary glaucoma, exfoliation syndrome, or malignant melanoma. Protein, uveitis, lens-induced glaucoma. Foreign particles, viscoelastic and alpha-chemo. Alteration of trabecular meshwork. Steroid-induced glaucoma. Edema, as in uveitis, scleritis, and alkali burn. Trauma, angle recession. Intraocular foreign body, as siderosis and calcosis. Clogging of trabecular meshwork by red blood cells. Red blood cells in hyphema. Blood breakdown products, hemosiderin-laden macrophages and ghost cells in hemolytic glaucoma. Clogging of trabecular meshwork by macrophages, where macrophages engulf foreign material and obstruct filtration angle. Foreign material may be denatured lens proteins in phacolytic glaucoma or melanin. Phacolytic glaucoma, acute secondary open-angle glaucoma associated with hypermeteoric cataract. Milky anterior chamber crystals and free high molecular weight lens protein incite a macrophage response. Macrophages engorged with denatured lens proteins obstruct filtration angle. Absent lens-associated uveitis, prominent neutrophils. There are occasional giant cells. Melanin, Angle obstruction by melanin-laden macrophages. Melanin is derived from necrotic melanoma as melanomalytic glaucoma and necrotic melanocytomas as melanocytomalytic glaucoma. Clogging of trabecular meshwork by tumor cells. Anterior tumors, seeding of tumor cells, direct infiltration. Ring melanomas infiltrating iris ciliary body root for 360 degrees. Large posterior tumors produce closed-angle glaucoma due to iris neovascularization, forward displacement of lens iris diaphragm resulting in posterior synecdoche and iris bombay. Clogging of trabecular meshwork by pigment particles. Pigmentary glaucoma or pigment dispersion syndrome. Secondary open-angle glaucoma produced by pigment granules released from ruptured iris pigment epithelial cells and deposited on anterior chamber structures. This is a bilateral condition affecting young myopic males with iridodonesis with inverse pupillary block. Incidence of secondary open-angle glaucoma varies from 25 to 50%. Pathogenesis. Campbell's theory. Zonular abrasion of pigment from peripheral posterior iris pigment epithelium as a result of posterior bowing of the iris. Similar mechanism secondary to sulcus fixed posterior chamber intraocular lenses. Secondary to iris chafing and erosion by the haptic or the haptic-optic junction. Krukenberg spindle, vertical pigmentary band on corneal endothelium, melanin phagocytosed by endothelium. Iris transillumination defects. Radial, mid-peripheral spokes correspond to zonular bundles. Heavy trabecular pigmentation, trabecular meshwork blocked by melanin. Pseudoexfoliation of the lens capsule, exfoliation syndrome or glaucoma capsulaire. Secondary open-angle glaucoma due to deposition of fibrillar material in anterior segment of the eye. Exfoliation syndrome is age-related, more common in Scandinavian elderly population older than 70 years. It is bilateral and asymmetrical. Incidence of secondary open-angle glaucoma is more than 50%. Pathogenesis. Generalized basement membrane disorder. Electron microscopic evidence for synthesis of pseudoexfoliation material within trabecular meshwork is present. Histochemically, material resembles amyloid. The material is found on lens epithelium and capsule, pupillary margin, ciliary epithelium, iris pigment epithelium, stroma and blood vessels. Angle heavily pigmented. Sampolisis line, inferior pigmented deposition anterior to Schwalb's line, anterior lens capsule deposits, central and peripheral area of deposits, intermediate clear area where the iris movement rubs the material from lens capsule. Are iris transillumination defects due to peripupillary atrophy. Zonular weakness is present, resulting in phacodonesis and iridodonesis. Alteration of trabecular meshwork by edema. Glaucomatocyclitic crisis, Postner-Schlossman syndrome. Recurrent attacks of open-angle glaucoma associated with minimal inflammatory signs. It is unilateral, affecting the age of 20 to 50. There is mild iritis with few keratic precipitates and trabeculitis. Fuchs heterochromic iridocyclitis. This is a chronic unilateral low-grade iridocyclitis. The affected age is middle age and it is a unilateral condition. There is low-grade asymptomatic uveitis. Finds delayed keratic precipitates. Involved iris is lighter in 90% of cases, and secondary open-angle glaucoma occurs in 10 to 50% of cases. Corticosteroid glaucoma. Increased resistance of aqueous outflow in trabecular meshwork as a result of prolonged use of topical, periocular, inhaled, or systemic steroids. Associated posterior subcapsular cataract is present. Schwartz-Matsu syndrome. Open-angle glaucoma in eye with chronic rheumatogenic retinal detachment. Trabecular meshwork is blocked by photoreceptor outer segments. Alteration of trabecular meshwork by trauma. Damaged outflow pathways. Post-contusion angle deformity. Anger recession glaucoma. This is chronic unilateral secondary open-angle glaucoma, manifesting months to years following blunt ocular trauma. It is caused by a blunt trauma resulting in contusion. Lens acts as ball valve. Tear in anterior face of ciliary body, splitting between longitudinal and circular muscle fibers. Mechanism of angle recession glaucoma. Late glaucoma in 7 to 9% of eyes with more than 240 degrees recession. Glaucoma is caused by scarring, endothelialization, and desymmetrization of trabecular meshwork. Secondary synechial closure can hide recession clinically. Fusiform configuration of ciliary muscle results from ischemic atrophy of its inner part. Post-trabecular mechanisms. Elevated episcleral venous pressure, arteriovenous malformation as carotid cavernous fistula, Sturge-Weber syndrome, orbital varix. Venous obstruction, cavernous sinus thrombosis, thyroid ophthalmopathy, retrobulbar tumors, superior vena cava obstruction, and mediastinal syndrome. Elevated episcleral venous pressure may also be familial. Carotid cavernous fistula, abnormal communication between internal carotid artery and cavernous sinus that could be idiopathic or as a result of head trauma. Types include low flow fistula and high flow fistula. High episcleral venous pressure more than 10 mm mercury. Dilated episcleral veins, ocular ischemia, venous stasis retinopathy, and glaucoma.